I think we're really just touching on the tip of the iceberg with all of this stuff. And we really are just now even seeing that this is part of how the human body functions.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome back to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we'll speak with Dr. Mairin Jerome about orthobiologics and regenerative medicine and dysbiosis. I didn't know what that was either. Dr. Jerome is from the Big Apple, New York City. She did her undergraduate at Brown University in studio art with an emphasis on sculpture. She went to medical school at the University of Vermont College of Medicine. She completed her residency at Emory University School of Medicine, my home program for residency, and was recognized as Resident of the Year 3 years in a row and served as chief resident during her last year. She subsequently went to fellowship in Interventional Orthopedics and Regenerative Medicine at the Centeno-Schultz Clinic in Colorado. Dr. Jerome is obviously a person of many talents, yet remains personable, passionate, and what I believe to be a pioneer of the field of regenerative medicine. We briefly touch on a fascinating topic I was unaware of until I met Dr. Jerome, a dysbiosis of the intervertebral discs, which I will save the explanation for Dr. Jerome later in the podcast, but I'll make sure to link the study we reference in the show notes. As always, thank you so much for watching or listening. I hope you enjoyed this episode to learn something. All right, well, let's get started here. Dr. Jerome, thank you so much for your time and coming onto the show. Today we're talking about regenerative medicine.
Thank you, Dr. Davis. It's a pleasure to be here and nice to talk with you today.
So just to get started, I was just curious because not many people know about it. I think it's becoming more popular these days, but just regenerative medicine, basically how you got interested in kind of pursuing that field.
Mm-hmm. So my background training is in physical medicine rehab, also called physiatry, same as you. And one of the reasons I was interested in this specialty is that you can pretty much take anything that you're interested in and somehow apply it within physiatry. Mm-hmm. So when it came to deciding what I wanted to do, I knew that I liked doing procedures, and I understood a little bit about PRP or platelet-rich plasma before starting residency, and it was something that was interesting to me. And once I became more exposed to these types of treatments, both during residency and then in particular shadowing a fellow resident who I now work with, Dr. Chris Williams, when he was in his fellowship out in Colorado, it made so much sense to me in terms of the biomechanical approach that's a little bit different than the traditional pain practices and fits the way that I think. And it was interesting to me both as a patient and would be what I would like for my family as well. So yeah, it was between that and brain injury and went the regenerative medicine route.
Well, there's big difference between those two. So how do you define, or what is your understanding of what regenerative medicine is?
Yep. So the way that I think about this type of medicine, and regenerative is a little bit of a misnomer. There's only a certain areas where it really truly is at this point regenerative in terms of reconstituting or helping people regrow tissue types. There's certain areas where that does happen. What I like to call the field in general is a newer term that has been formed called Interventional Orthobiologics, previously Interventional Orthopedics. And what that means is there's a big gap between conservative musculoskeletal management, where you have maybe some physical therapy, and if that's not effective, maybe a steroid injection. But for many, many years, we just kicked the can down the road until people were ready to have surgery. And there's a whole group of patients in between those two treatment modalities that can be intervened upon with these types of injections. Similar to interventional cardiology, for example, previously when patients were having a heart attack, they would have to have their whole chest opened up and a very large surgery until people realized that they could go in percutaneously, meaning through the skin minimally invasively with just needles and imaging guidance. Very much interventional orthobiologics is similar kind of concept for musculoskeletal medicine.
And so if it's not regenerative, what do you kind of tell patients, and how do you think of it as when it comes to these interventional sort of orthobiologic procedures?
The areas where it is regenerative, I should start out by saying, is typically in ligament and tendon repair, where you can actually stimulate the regrowth of collagen fibers that are unable to grow without that stimulation, and have them essentially knit back together. And once those injuries are healed, they're healed. Where it's less concretely regenerative is more of the degenerative processes, like spine degeneration and any type of osteoarthritis. However, what we believe, there's a couple of different mechanisms through which these injections can be helpful. One is with the stability overall of a joint. And we can talk a little bit more about that and how that's different from treatment with just steroids. And also with changing the microenvironment. So the two big things we want to intervene on is switching the pathway from chronic inflammation, which I think of as like a smoldering fire, and it just kind of eats away. It's more of a catabolic process, or eating away at the tissue over time kind of process, and stimulate the body to return to acute inflammation, which is more of that short-term healing that can actually change the environment from pro-inflammatory to less inflammatory. So that's one way in which we think that these treatments work. And the other way is most often, and this is something that I didn't really learn until fellowship, there's a period of time of instability typically that precedes arthritis. So we think of arthritis as being stiffness and immobility. However, over time, we get kind of a wear and tear situation happening with our joints, similar to if you had or driving a car and the lug nuts on the wheel were loose, the tire would wear out more quickly. So all of our joints are encased for most joints with a capsule, like a balloon that sticks them together, and then supporting ligaments and then tendons, which are controlled by the muscles that all function together to keep the joint stable. And if there's an injury or instability in any one of those areas or multiple areas, then over time the body tries to make the joint more stable by laying down new bone, which is then a bone spur. So because we're not injecting steroids, which typically weaken those types of structures, we're actually injecting things that can, for lack of a better word, tighten up the ligaments and help things be more stable with a variety of different options. That's another aspect that we're intervening upon.
That's awesome.
To actually healing, ACL tears and rotator cuff tears and things like that.
It's a really good analogy, actually. I've never heard put that way as well. Certainly like this inflammation cascade and this release of, cytokines and other inflammatory signaling markers is interesting because in some ways, it seems like a self-fulfilling prophecy that, when you release more inflammation may sort of occur. But that's a really interesting perspective and one I hadn't heard of. So that's really cool. Is there a average patient that you see in clinic that kind of fits this paradigm, or is it just kind of everybody at this point?
Let me add one more piece to the mechanism,
Sure,
and then I'll get to that last question. A lot of what this comes down to is wound healing. So when you think about how a scab is formed, for example, unless somebody has uncontrolled diabetes, in general, our skin tends to heal pretty well if it's a laceration because we have a lot of blood that goes to those areas. When that happens, our platelets bind to the injury and make a clot, and then send out all sorts of different signaling proteins, that inflammatory cascade, to signal to the surrounding area, hey, I'm injured, come over here and heal this up. So it's a very similar concept and mechanism with either platelet-rich plasma or bone marrow concentrate and sometimes adipose tissue that we use to stimulate that same healing response. It all comes down to blood flow. I mean, really, some of my biggest takeaways from being in medicine or for your health, don't smoke and exercise, and both things really have to do with blood flow. So we found that by taking these substances and concentrating them and very precisely delivering them with a needle to the area that's injured or inflamed, it can help stimulate that process in areas of the body that don't have a very robust blood supply otherwise. So tendons, ligaments, spine, cartilage surfaces, those kinds of places. So in terms of the patients that we see, everybody in this specialty, well, I would say there's two kind of camps, well, maybe three, who are more regenerative medicine or interventional orthobiologic physicians. There's some orthopedic surgeons who are doing this at a very high level and combining with surgery. Then there are many physiatrists who are also doing this type of work, often in combination with spine and peripheral joints. And then there's sports med, strictly physicians who may not do as much spine and treat just the joints. But pretty much any area that you can reach in the body safely with a needle could potentially be intervened upon. My personal practice is about 50% spine. Majority of that is lumbar, almost 50-50 lumbar cervical, I would say, split, and then a very small amount of thoracic. And then the rest are peripheral joints, knees being the most common. We tend to have pretty good outcomes with knees. So patient age-wise, my youngest patient probably been about 16, oldest patient in his 90s. So there's a very, very wide age range. It depends. There's very high-level athletes that I see, professional jiu-jitsu athletes, things like that, who have more acute injuries. There's still some developing research on that in terms of when to intervene. Typically, I wait at least 6 weeks and allow things to try to heal on their own. But, seeing people with a ligament injury, tendon tear, rotator cuff tear, and then patients who are just developing some arthritis and who are either interested in this type of technology and have tried some conservative things before and want to avoid surgery, or patients for whom there's really no good surgical option and they've tried everything else. So, and I do also work with a group that has agreements with certain employers who self-insure. Because the biggest thing with this specialty, unfortunately, at the moment, most commercial insurances do not cover these procedures. So the patient population can be somewhat self-selecting in terms of patients who can reasonably afford to do them because the cost is much higher than if you were going through an insurance. However, the cost in general for the procedures is lower than what would be billed for a surgical procedure. So a smart group of people got together and went directly to employers who self-insure their employees. And for certain indications where there's a high level of evidence, there is insurance coverage for those patients, which is nice.
Do you almost always prescribe physical therapy in conjunction with these procedures that you offer that we can talk later about?
I don't think I've ever not prescribed physical therapy in conjunction with this. So the rehab is, just being a rehab doctor in general, I think we tend to appreciate how important that is. I mean, exercise truly is medicine. The other thing that, one of the many things that improves your blood flow. But the other thing that's very important about the rehab is there's different stages to the healing process of these after these procedures. So we want to do everything we can to optimize the patient outcome, both, internally in terms of optimizing someone's own internal health, but also we need the mechanical input of force to go through the area, specifically starting at around 2 weeks. The first couple of weeks is generally the inflammatory phase. And from weeks 2 to 6, it's the proliferation phase where you're actually laying down new collagen fibers. And when we study this in a lab setting, if you don't put mechanical load through the area, then the tissue will just grow in a disorganized manner. So we really need to get that mechanical input and signal so that the tissue knows which direction to grow into. So it's hugely, hugely important to have a really solid rehab program. And we give a rehab progression guideline for each patient, depending on what injury they have, what we're treating, and what treatment is used. So, yes.
It's wild how fast the body decays. When you're laid up in a rehab hospital, for instance, like we're familiar with, or in the ICU, the rate by which you lose, even for instance, your like quadriceps mass is on the scale of days. It's just wild. So yeah, that impulse, it makes a lot of sense. Then in conjunction with doing things like these interventions, makes a lot of sense. So how do you evaluate a patient like for these procedures that you offer?
Yeah. And just on that point that you were saying, I mean, at this point, we're living as humans, we've extended our biological ages by a much greater extent, and we're living longer than we ever have before because of all the medical advances. And because of that, now the primary condition that limits functionality worldwide and limits quality of life is back pain. So it's a huge public health issue, and kind of similar to a bioidentical hormone replacement type of thought process, which at this point I would say there's quite a good amount of evidence for. But since we're living so much longer, why not optimize our quality of life in the meantime? Because people are spending the last decade or so of their life in poor health. And much of that has to do with your level of activity, which, if anybody hasn't seen it, looking up the study that compares triathletes in their 20s all the way through their 70s and comparing them with sedentary people. They took MRI slices, as you mentioned, of the quadriceps, and it's pretty amazing just visually seeing a giant rind of fat essentially around this very tiny muscle. And the muscles themselves have huge implications for our health and brain health and everything else. So the more we can do to help people stay active and functional and decrease downtime after a surgery is hugely important. In terms of the evaluation, it does take a little bit more time than traditional office visits. So I usually spend at least an hour with every patient that I see for a new evaluation and try to put all the pieces together. So, for example, if I'm seeing a patient with knee pain, I always ask about low back pain and do a screening to make sure there's no underlying radiculopathy. Because the other piece of this is we want to figure out what biomechanical process is driving the injury to begin with. Was it something mechanical that happened, or is there a compensation over time because of a low-grade radiculopathy that, could be addressed with physical therapy as part of the treatment plan, or potentially some injections or to help put everything together from a biomechanical perspective. So if I'm evaluating a peripheral joint, I always use ultrasound to assess the soft tissue, the articular surfaces that I'm able to see with the ultrasound, and then the dynamic stability or lack of stability of the joint capsule itself. Obviously look for any effusions, that kind of thing, and try to be as comprehensive as possible, both in understanding the patient's full musculoskeletal picture, level of activity, what their goals are. The other thing to keep in mind is if somebody does have a low-grade radiculopathy from the neck or the back, and treating a shoulder or a knee, for example, they might have more pain after the procedure because through creating more inflammation, these procedures can be pretty uncomfortable to recover from compared to a steroid injection, for example. And depending on what we use determines that level of inflammation. So PRP is moderately uncomfortable and usually is more painful and stiff anywhere from 4 days to 2 weeks. But that can linger a little bit longer. So I always like to warn people of that and have a good plan for pain control and activity afterwards so people can arrange their life for procedure timing around those things. And so, yeah, I would say that the evaluations tend to be a little bit longer. I always want to know about their health history, what other medications they're on, if they tried physical therapy, what they've done for these things in the past, and be thorough with the neuromuscular exam.
And then moving on to what procedures you offer to patients. So what is it that you say that you might think what you would offer to patients that might differ from, when you go to your primary care or to a pain clinic or, to a sports clinic, for instance?
One thing that I always try to do is be very objective and straightforward with patients. One of the unfortunate things about anything new in medicine is that, especially if things aren't covered by insurance, there are some bad actors out there who either aren't trained properly, are not doing treatments comprehensively, or are just completely unethically approaching these kinds of treatments and not doing what's right for the patient. So we do have candidacy grading for each condition that we see based on the data that we currently have. For example, severe knee arthritis still does extremely well with bone marrow concentrate injections, especially subchondrally underneath the cartilage surface. So even if somebody has very severe knee arthritis, they may still be a good candidate as long as there's no major architectural distortion in their knee, versus hip arthritis is not as successful. So the chondrocytes are the cartilage cells that live in the hip, and most people are chronologically older than the same cells that live in the knee, most likely because of the forces distributed through that joint. So I'm always very honest with patients, as honest as I can be with the information that I have based on the data that we have and then my experience treating patients. So we'll always say you're either a fair candidate, good candidate, fair to poor, or a poor candidate for this. So anybody that I would see, for example, with very severe hip arthritis, I would say you're a poor candidate for this, less than 50% chance of having significant improvement with these injections. My recommendation would be to talk to a surgeon about getting a hip replacement. They're very successful procedures, and you're more likely to have success with that type of thing. And some patients say, you know what, I would rather just try anything, and as long as it's reasonably safe, as long as you have that conversation and they're aware of what they're getting into, it might be worth trying something, because you can always be surprised. For example, I had recently a patient who we had treated her right before her 89th birthday. She has very severe knee arthritis. And for her architecture of the knees was completely demolished. Her ACLs were gone, stuck in valgus alignment, unable to fully extend, and greatly impacting her mobility. She had a couple of steroid injections, I believe, in the past, no aspirations, but big effusions in both knees. So I advised her to talk to a surgeon about just getting her knees replaced, just because of the shape of the joint. She said, I don't have time right now to go through the rehab and recovery from a knee replacement. I have lots of traveling I want to do. I really want to try these anyway. So we kind of split the difference and said, okay, well, let's try PRP. It's a less invasive procedure, less costly. We'll get a sense of how you respond to these things. And as comprehensively as possible, treated her knees with PRP at a high dose, as well as the remaining supporting ligaments. And she's actually doing great, like at least 50% better than before. She's walking around more easily, and is so far pretty happy with things. So, it's always a conversation with the patient and making sure that you're educating them on the likelihood, and then documenting the conversations, just so that there's good communication and good understanding. So hopefully that answered your question. But I guess so. Well, how would it be different than a traditional pain practice or traditional sports practice? Although I'd say more and more people are offering these procedures.
Definitely.
The big difference, I would say, is just the number of structures that are injected. So we're here vening more on an osteoligamentous type of paradigm rather than putting out the fire of the pain, if that makes sense. So with steroids, I kind of think if you have a disc herniation and you have a steroid epidural for a radiculopathy, it's kind of like putting out the fire at that one level, so that people can be comfortable enough to then do the rehab that helps them ultimately get better. Because really, most things, or many things over time, if you give it enough time, will heal on their own. What we do is actually, to some degree, modifying the health of the tissue. So we do know that epidurals done with platelets or median nerve hydrodissections with PRP last longer, and in general are a bit more successful than using steroids alone. And we also tend to include the joints and the ligaments with these procedures as well, because of the small micro instability that occurs with disc height loss that changes the mechanics and the forces going through that area, and treat things a little bit more comprehensively, even including using the platelet-poor plasma that's left over from making the PRP, because it's been shown, at least a couple of studies at this point, to help increase the statolite muscle stem cell activity in muscles, in the multifidus muscles specifically. So it's almost like a trigger point injection into those muscles to help. Yeah.
And so in particular, it seems that your clinic would tend to use bone marrow aspirate more than, say, pain clinic, for instance. And so the medicinal signaling cells is, to my understanding, a big part of that. Is that sort of, and how is that different than the PRP, for instance?
So colloquially, those terms are medicinal signaling cells, I think, is the current terminology. Previously, it was mesenchymal signaling cells, and that's how we call them, stem cells. So many patients still refer to these things as stem cells. That FDC is regulating that, and really more accurately, we're supposed to call them signaling cells, because it's truly what they are. Outside of an FDA-approved investigational new drug study, cultured mesenchymal or medicinal signaling cells are not permitted for use in the U.S. Initially, actually, people were doing that. It looks like it's very safe, and most likely is pretty promising, especially there's some data coming out of Spain right now, where some pretty significantly large areas of injury. Like I remember seeing an Achilles tendon in particular at a conference with somebody presenting who had that was more than a centimeter retracted, huge, looked like it needed surgery, but they actually were able to induce healing with that. So in the future with scaffolding and different things, I think there's going to be a lot of promise and kind of emerging of these biologic procedures with surgical interventions. But getting back to your question, so the mesenchymal or medicinal signaling cells, I still call them mesenchymal.
Yeah, right.
It's technically more of the stem cell procedure. And what we do in the US, you have to re-inject the tissue within 24 hours, and it can't be manipulated beyond concentrating it. So to be FDA compliant. So that goes for adipose tissue and for bone marrow concentrate, and you have to re-inject it within the same tissue type. So you can't, transfer cells from a different lineage and put them in a place where they wouldn't necessarily belong, which gets a little tricky with adipose tissue if we're treating that orthopedic injuries with that. But there's some argument that, they have the Hafez fat pad and different as well. So sticking just to the bone marrow, initially we thought the mesenchymal or medicinal signaling cells, which are the lineage for musculoskeletal type of cells, bone, cartilage, muscles, tendon, were the cells of interest. It turns out actually, so what we end up injecting is the entire bone marrow aspirate, but concentrated down. So there's multiple different cell populations in there. And in order to identify how many medicinal or signaling cells you have, you actually have to culture them in a lab. And that's how many you get is dependent on the culturing techniques and the batch. So it's very, very hard to study, actually. There are some ELISA panels that can look at markers on the cell, but I guess it gets kind of in the weeds with all of that. But what we do know is that in general, the number of total nucleated cells is an indirect marker for the number of medicinal signaling cells that are within that population. And it also, the more we're learning about this, there are probably other cells of interest that are also helpful. So we do have very good results with that, even though it's not a cultured, just purely one cell population with these injections. The use of, I use more often than not PRP for many things. They're the platelet-rich plasma, which is the blood draw. For things that are more moderate to severe in severity and pathology, tend to do a bit better with the bone marrow concentrate procedures. And for anything else, things that are more minor to moderate, PRP is a good place to start. For spine, most of the time, even if it's a very significantly degenerated spine, platelets still tend to work quite well for that, just because of how tiny the areas are and the concentrations that we can get to. But the interesting thing about the bone marrow is there's a couple of studies out of France with an orthopedic surgeon who is one of the founders of this specialty, who there's two studies in particular. One, he took 70 patients, or 140 patients total, 70 in one group, 70 in the other group, and both knees had severe arthritis, candidate for knee replacement in both knees. And he replaced one side and did a bone marrow injection, not into the joint, but into the bones underneath where the cartilage was degenerated. And he also biopsied the bone marrow from the knee joint itself and cultured the cells, and they didn't grow. So there's something happening on the cellular level with the cells not being able to reproduce the cartilage and things like that, where they kind of peter out and they're not very healthy. That is underlying part of the process that contribute to the development of osteoarthritis. So you follow these patients for about 15 years on average, and the range is from 10 to 20 years. And the patients, only 25% of the patients who were candidates at the time of the injection went on to knee replacement in the injection side. So it's pretty impressive data. He found that bone marrow edema greater than 3 centimeters was an independent predictor for patients moving on to having a knee replacement. And then he did the same study essentially with 60 patients in each group, looking at injections of the bone marrow concentrate alone into the joint itself versus into the bone. And those lasted about twice as long when you inject into the bone. So the concept there, in addition to just the washout effect potentially with the joint fluid, is that when we transplant the cells that are functioning in a healthier manner, and there's a variety of studies that look at that, but what it comes down to is you want to draw the cells from the back of the pelvis, the posterior superior iliac spine. And the draw method is really important. The way it's concentrated is very important, and then the delivery technique is very important. But the concept is, if you inject the cells into the bone underneath the cartilage surface, what we suspect is that we're helping to repopulate that cell population so that it's healthier and better functioning over time. And actually, for that study, they did have improvement in the follow-up MRIs at 2 years for the cartilage thickness in the injection groups.
That's pretty amazing. Do you know if the sort of in vitro, if they had done like an in vitro sort of arm as well when they used some of that cultured, I guess the aspiration within the bone, and then try to inject some of the bone aspirate too into that to see if they repopulated part of the chondrocytes in it? Or
they didn't biopsy afterwards to which would be a great follow-up study actually. But what they did do is they cultured a small portion of the cell population that they did inject before they took a piece of just a small volume of it, and then they did culture them because they measured the number of cells that were injected and all of that. So definitely, comparing the biopsy from the diseased knee compared to the aspirate from the pelvis groove, and the arthritic knees did not.
Oh.
So
how much of your conversation revolves around education expectations for these procedures? And how important is that to you when you have these discussions?
It's very important. Anytime you always have to weigh the risks and the benefits with any type of intervention for a procedure. Even if it's a low-risk procedure, the risk is never zero. So the benefit of doing something and intervening always has to outweigh the potential negative consequences of that. And, many people come in and will say, I want to be pain-free. And that's typically not a super realistic expectation. Most people have to the age of 20, I would say. It's never 100%. We're not resurfacing whole joints and, reversing the biological clock in that manner to returning people to, before there was any kind of wear and tear at all. So I always try to set that expectation and give people an idea of, based on the data that we have and our experience in our registry, because we collect outcomes for all of our patients. I would predict that based on what you have going on, your other risk factors, how long this has been going on for, the degree of pathology, and then the treatment that we're discussing, I would expect at least, 50 to 60% improvement, or 75% chance of having at least XYZ improvement with this treatment, just so that people understand. Usually I actually make it a little bit lower than what I actually think, because I don't want to oversell anything. Because for many people, one of the biggest risks of these procedures is that they're paying out of pocket for something that we really can't guarantee is going to work. I think if this was covered by insurance, it would be a no-brainer for many pathologies to try. And I always counsel patients on their other options as well, to make sure that they understand, if we were going through traditional insurance, these would be your options. If you haven't tried that, you could certainly, I'm happy to make a referral to see somebody for those things. And if you want to exhaust all of the options outside of surgery, this is what I would recommend. Have that conversation so that people are knowledgeable and understand something about basically walk away from the conversation, understanding what their diagnosis is, what their options for orthobiologic management would be, the chances of success for those treatments, and their options outside of that treatment paradigm, as well as the recovery. Because many people will often not believe me in terms of how uncomfortable things are after, especially certain areas of shoulder, the elbow, for tennis elbow, rotator cuff tears. It's pretty uncomfortable to move because you're creating all that inflammation, and they're joints that are hard to not move, even just gripping that will set the elbow off. And there's a lot of restricted range of motion as well. So people are often surprised with how much pain there is after the procedure. And it gets better very quickly. But I always like to set that expectation, especially because it takes typically between 6 and 12 weeks to start noticing significant improvement, oftentimes closer to 12 weeks, depending on what we're treating. So I always like to make sure that I have that conversation so people understand the timeline, and that it's not an overnight process and what to expect from that standpoint.
You sort of just answered this question, but for the people that can't come to see you in Atlanta, what would you say for those that might be listening to this episode that are interested in pursuing an orthobiologic treatment or procedure? What would you tell them now?
What I would say is try to find a physician who has reputable training in the field of musculoskeletal medicine in general. There are some, nothing against chiropractors. I work with a lot of chiropractors who are really fantastic. However, injections are not typically part of what they would offer. And so there's some clinics that hire mid-level providers or outsource to other people to sort of do injections and provide information to patients that is not potentially accurate. For example, birth tissue products, umbilical cells, those types of things are not FDA compliant whatsoever in the US. And patients will be told, oh, you're too old. Your stem cells aren't good. You need a birth product. When really, in fact, if you try to culture those off-the-shelf products, there are no cells in there. So it's like a less good PRP. And there was an issue with contamination of E. coli with these products, which is serious health concern. So number one, find someone who has, a physician with a background of musculoskeletal medicine who is trained specifically in these procedures. And the way to evaluate, there are some good questions to ask during a consultation. If you're not clear on their training, try to find out more about what that is. And then find out how they dose the platelets or the bone marrow. If they count the platelets and if they count the cells, because the dosing is very, very important. So we know, for example, for knee arthritis, we want 500 million total nucleated cells or more to have a good outcome. And so we actually count those cells so that if we're treating two areas, for example, and you have, 600 million cells, you would want to focus just on one area and postpone another treatment for another time, just so that you get the patient the best results. So asking those questions is very good. And then all of this should really be done under image guidance. Kind of poking around and just injecting in a joint is okay for steroids because it's kind of a gunshot anti-inflammatory response. But when you're trying to utilize these treatments to the highest degree possible, you want to make sure that the platelets or the cells from bone marrow concentrate are being precisely injected into the areas of injury. So into the meniscus tear, directly into the ACL. Do they use ultrasound guidance? Do they use X-ray guidance or both? I use a combination of both for most procedures. And so I would say make sure that the dosing is appropriate or that people are even considering the dose of something when they're injecting it. Are they using image guidance? And then what's the training? And then what's the processing like? Is it one size fits all, you get out what you get out, or is there some way to modulate that or alter things based on the treatment plan? Otherwise, you're kind of like giving a medication without giving a dose.
Awesome. Thank you very much. And I'm sure a lot of people are appreciative. I know my dad and I talk about that for his hip too. And I think that that'll probably be the option we pursue as well. And, it's very rare to find people that are thoroughly trained both in musculoskeletal medicine and then in regenerative medicine. And like you had mentioned, I think the crux of the issue is that we don't have a lot of quantitative data. As you had mentioned, knowing the volume, the level, the amount of platelets is really important. And I think we need to continue that pursuit in quantifying these things so that we're not just poking and prodding around, and especially using image guidance to know where exactly this medication is going. And obviously some of it will spread, but even still, I don't see how you could do it without image guidance.
Yeah, exactly. And, for labral tears and things like that of the hip or the shoulder, if you get the cells in the joint, typically they will settle into the labral tear, but why not also try to inject it directly into the tear itself and give it a better chance of healing? And that is part of, I think, it always takes a lot of time to change anything in medicine. But much of this, when we first started doing it, people just didn't know, they were counting things. They didn't know how much needed to be put in, or they would, stop the study too early before the effect really took off. So a lot of the data a lot of I think physicians have the impression that, this doesn't work, or sort of snake oil, that kind of thing. But, if you understand the nuances of how to read the literature, and there are multiple studies at this point that are documenting classification schemes for publishing specifically, so that how the dosing was done, counting whether it's leukocyte rich or leukocyte poor, whether it's activation or not of the platelets. All of that is super, super important as we learn more about this and make the treatments available for people.
Awesome. We're going to kind of switch gears here. I don't want to take up too much of your time, but so a very interesting thing that you and I had discussed just very briefly, and something I actually wasn't even aware of, is this idea of a subclinical infection or dysbiosis and inflammaging. So aging with inflammation. And I was just going to ask you, what is this idea of the spine or disc microbiome?
Mm-hmm. This is where I take out my nerd hat. I think this is such a fascinating field, and one other sort of just broad concept with all of this stuff that I think is one of the reasons I was also very interested in this specialty is I've always been very interested in the natural world and biology and these types of things, and even like modeling architectural environments after the natural environment, that kind of thing. What was that?
Yeah. And sculpting as well, right?
Yeah, yep, exactly. Which I think this is a very creative field, which also appeals to me. But nothing that we could do as humans will ever be as intelligent as what's happening in our body or what nature has created, until maybe we'll get there at some point with AI. So I think it's really fascinating to the concept of taking something that's already existing within the body and just letting it do its thing by just facilitating the delivery of it. And personally, I think that this will be the future of medicine, I hope, as we get more and more sophisticated with our understanding of biology, which leads into the next subject about the microbiome, which for much of history, since the identification of bacteria in general, and Lister also, I will say, everybody thought he was crazy when he proposed the idea of bacteria. And turns out he was correct. So as I navigate this field, which I didn't appreciate probably when I went into fellowship, there's a lot of pushback. I think it's happening less so now as we get better data, but initially I was surprised at the lack of acceptance of some of these newer treatments, which, again, hopefully we're making some progress with. So for the longest time, because of the culture techniques, we could only grow a certain amount of bacteria. And so all these areas of the body we thought were sterile, just because we didn't have it's like, looking at the night sky and trying to understand what's happening there and then getting a telescope. So the telescope in this situation is the next-gen sequencing and the ability to identify bacterial RNA and DNA from samples. And there's one very fascinating study out of India where they biopsied MRI normal spinal discs and did the DNA or RNA sequencing, then took fragments from just run-of-the-mill degenerative disc disease during surgery, and then disc herniations where they're doing a discectomy as well. And they looked at the RNA profiles of all of the bacteria in there. And it turns out our spine is not sterile. In fact, probably nothing in the body is sterile. And they've even found now that we have bacteria that's dormant in our blood. And we have more bacterial cells just in our gut. I think there's 13 trillion compared to 7 trillion human cells in our body. So we're mostly made of bacteria, it turns out. And then the balance of these bacteria also helps with our overall health. So I think we're really just touching on the tip of the iceberg with all of this stuff. And we really are just now even seeing that this is part of how the human body functions. But we do know that with changes over time with our diet, one of the things that likely is driving obesity and other health problems is an imbalance of the gut microbiome, often because of lifestyle and environmental factors. So that this one study in particular has identified that there is the bacteria lives natively in our spines. It's supposed to be there. And the greater abundance of bacteria and the greater number of species of bacteria is associated with better health of the disc itself. So before this study came out, people were actually looking at C. acnes, Tritiobacterium acnes, which previously was called P. acnes, because it's a specific type of bacteria that secretes acid. And the acid has been thought by some people to start to erode the end plate of the vertebral body, and is one of the reasons that people get modic changes, painful modic changes that we see on MRI imaging. So we don't know really enough about this, but they did show in the study where they biopsied the spinal discs that there's a greater abundance of bacteria in the healthy discs and a lower number of diversity of species in the unhealthy discs. Mm-hmm. Therefore, we haven't confirmed this entirely, but there's probably something happening with the balance of bacteria that's affecting the health of the discs or making them more susceptible to having a disc tear or degenerating in general and having some back pain.
And I think within that study you're mentioning, there was, and I'm not sure if it's statistically significant or not, but the Pseudomonas species was found to be in a greater abundance in degenerative discs or herniated discs than would be the normal discs. All of it was just a little bit mind-blowing for me to read that study.
Yeah. I mean, it really is mind-blowing. I'm not sure what to make of the Pseudomonas, but you're correct. They did find that Pseudomonas was growing in a greater abundance in the diseased discs compared to the healthy ones. Interestingly, if you look at the cases of discitis, especially after interventional orthobiologic procedures, this is one area that I've studied because there have been disc tears, as I'm sure you're aware, are extremely difficult to treat. It's one of the things that doesn't respond that well to surgery. Injection techniques and different techniques for treating that type of pain specifically has not been very successful over time, and remains a bit of a dilemma in terms of providing people with really good options. Intercept, I think is a good procedure. Hopefully you're learning that in your fellowship. But to date, the studies that I know of that really show that you can help to heal the disc are the intradiscal PRP studies that have been done. One randomized control trial with follow-up data for that shows 80% success with significant clinically improved pain reduction and function. They followed at 2 years and then 5. For well-selected patients, meaning discrete annular fissure, not a lot of disc height loss. And those injections also have to be done very precisely into the tear itself. What we do, but with that, there have been a handful of reports of discitis after these injections, more commonly associated with bone marrow injections compared with PRP. So some preliminary studies were done in vitro taking leukocyte. Well, there's one published study with looking at cefazolin added to in vitro PRP preparations with C. acne. Actually, C. acne is the most common pathogen that's found in these discitis situations. I haven't actually seen a report of Pseudomonas. Staph, I think, is the other most commonly reported pathogen. But C. acnes, by and large, is one of the most pathogenic species that we think of that can cause a discitis post-procedurally in these patients. So also, I think in the shoulder as well, because it lives kind of underneath the skin. So in order to prevent that, double needle technique is preferred so that nothing that goes into the disc actually passes through the skin. And studying cefazolin with the PRP preparations, there was incomplete clearance of the C. acnes. So another study was done looking at gentamicin with various PRP preparations, leukocyte-rich versus leukocyte-poor, with various strengths and concentrations of PRP. And we found that gentamicin with the leukocyte-rich, gentamicin cleared the C. acnes in each group, and this is all in vitro, but most strongly cleared the bacteria most quickly in the leukocyte-rich higher concentration PRP groups. So I do inject gentamicin now intradiscally with any intradiscal injection. And I always have that conversation with the patient that it's higher risk, about a 1 in 200 chance of possibly having a discitis, which means possible admission to the hospital, IV antibiotics, possible surgery. It's a big deal. And patients are pretty self-selecting in terms of whether or not they're willing to take that risk. If it's something they've been dealing with for a really long time and are a good candidate, then they might say, yeah, let's just do it. Versus, I always tell people, if you're it's always an option to start outside the disc first and see how much progress we can make to try to minimize any type of complication. But yeah, I mean, I think it's really it's fascinating to think about. There's also the gut spine axis microbiome.
Right.
It turns out that there's bacteria that are implicated in gene protein expression that is linked to the development of scoliosis. So I think as we learn more and more about all of this, especially now that we have the technology to better characterize the bacterial populations that are living within these areas and how we could potentially intervene upon them, I think we're going to see some very, very interesting changes in how we approach healthcare in general in multiple different areas. So, I mean, who knows? Maybe we'll have a probiotic, like a fecal transplant for the spine at some point.
The idea of a fecal transplant, when it started to come out and started to make mainstream media news, it was outrageous.
Yes.
Populace, myself would have thought about it. Like, well, indeed, like I think H. pylori, everyone was like a little bit suspect of a bacteria causing, disease like this. Do you think that you might pursue, like doing some research or like, because you have quite an awesome setup at your clinic. And I was just, and I know Dr. Williams, when he was there previously, he did quite a bit of research there too. So.
Yep. I'm peripherally involved in a few research studies, but it is something that I absolutely love, being involved in research. And there's one study that I had started working on previously, looking at caudal epidural injections for painful bladder syndromes and measuring nerve growth factor levels in the urine pre and post injections, because we do find that patients with painful bladder syndromes, interstitial cystitis type of symptoms, oftentimes will have an L5S1 disc tear. And the theory or the hypothesis is that there's irritation of the sacral nerve roots going to the bladder. And if you can calm the inflammation down over time, that potentially that helps to improve the outcomes. So short answer is yes. I'm not currently doing any direct basic science research at the moment. Where I was in fellowship, we had a university style research lab with PhD level scientists running it. So it was pretty amazing. And that, I think, is how Dr. Chris Centeno and Dr. John Schultz, who started the Centeno-Schultz Clinic, that's how they really were able to make a lot of progress in a short period of time, because they could say, like, how many platelets do we need to inject for tendons, and compare, tenocytes from a certain age group versus another age group, in vitro, and see what the response was to kind of determine some of these parameters and start really having some good outcomes with these things. So, yeah.
Incredible.
There's a lot left to learn.
But it's fascinating, and it's crazy because a lot of what we know today is the ability to continually parse out different smaller aspects of a larger whole. Mm-hmm. It said using a telescope to see the sky, mm-hmm. and I think using PCR and analyzing small fragments of DNA is a pretty fascinating thing that's happening like very routinely now. Mm-hmm. So I don't know what's around the corner, but as you had mentioned, maybe AI is going to be involved. I don't know.
Yeah, I think, it just gets so complicated that I don't even know if the human brain can really compute all these things. But yeah, absolutely. I think it's a combination of like looking at the really tiny microscopic detail, but then also being able to connect that back as a whole. I think in healthcare in general, we've become very siloed at this point. And, somebody's just looking at this one part and the other part, which is another reason why I love physiatry so much, because we really have the ability, I think, to look at the whole person. And therefore, it's a good fit for interventional orthobiologics in general with that thought process. But yeah, 100% completely agree. And very, very interesting place that we're in right now in science and technology. And, I think the regenerative medicine, it's wonderful. It's not, not everybody's a perfect candidate. Certainly if anybody has neurological deficits of any kind, like progressive leg weakness from a disc herniation, that's getting worse over time, and there's concern for permanent injury, of course, that's always a surgical referral. And I really, appreciate and respect and love to collaborate with surgical colleagues. And I think that there's a lot of opportunity for future collaboration with these types of things. Rotator cuff tears, for example, we know that if it's augmented with bone marrow concentrate after the repair, has or reduces the re-tear rate by a factor of 4.
Right.
because of the cells are not that functional in that area. So I think there's a lot of opportunity for collaboration, and this is, really just another tool in the toolbox of helping to improve pain and function for patients and promote overall well-being and good health in general. So yeah, and I think there's probably a big role as well for some of the neuromodulation and different techniques that you're probably learning about now, and maybe a combination of all those things as well. So yeah.
Yeah, I think the future is bright for pain and musculoskeletal issues. So, I'm learning incredible things here, and looking forward to what the future holds. I just hope I have the bandwidth to continue to learn all the new things that continually come out. So
it's hard to keep up. For sure.
Well, this is a great place to end it. Thank you so much for your time. It's been a pleasure talking to you.
Yeah, likewise. Thank you so much. I will say that there's 2 big conferences that happen every year for people who are interested in learning more kind of about the cutting edge techniques. It's a good place to get a synopsis and updates on what's happening for the interventional orthobiologic world. So one is TOBI, or the Interventional Orthobiologic Institute conference. I think this year, or in 2025, it'll be in August. And then there's the Interventional Orthobiologics Foundation annual conference, which is IOF, which is in February. So for anyone who's interested, they're great conferences.
Typically in Arizona, right? IOF?
Yes, IOF has been in Scottsdale the last few years. Sometimes it's in Colorado.
Yeah, I want to go. I'm definitely going to go at some point soon here.
So. Yeah, worth going for sure.
Definitely. Okay, well, maybe I'll see you there.
Yeah, that would be great.
All right. Well, thanks very much. I really appreciate it.
Yes, likewise. Take care.